Sir, please mute yourself. So if we see at the history, so before 2 decades, at that time, big incision, big surgeon, big incision, but now no incision, minimal incision. So that is the way of treatment. So in abdomen, so many things I write here. So this is MIS. So you can do esophagectomy, achalasia. So then halar myotomy, hiatus hernia. So then you can do fundoplication, intestinal resection, mesenteric, many things. So till piles, no piles we are doing with laser. That is also MIS. So you can do gynae procedures, chest procedures as well, spine, urology, neck, so many things I asked. So cardiac surgery. So this all is, we are till ortho surgery. Just I touch some of them. We can do with the technique of MIS, minimal invasive surgery. As I have mentioned, the role of laser is as well. So laser is also MIS, minimal invasive surgery. So we are in this era and going ahead. Just you can see, so these are commonly done MIS like diagnostic laparoscopy, bariatric surgeries, GI malignancies, achalasia, cholecystectomy, appendectomy, and many others. So till you can do now, we are doing routinely perforated ulcer, this peptic ulcer perforation if occur, because now PPI are dominant and there are less cases as compared to 10 years ago, 15 years ago. But again, sometime we face such a situation, then no need laparotomy, just with MIS. With laparoscopy, we can do this surgery. There are some advantages that I have highlighted. Improved diagnosis, definite. Just think about a female patient with abdominal pain. We have no idea if there is appendicitis, there is any issue in ovaries. Just you put the scope, you can see. So this is the beauty of this laparoscopy, and less tissue dissection, less wound infection, less chance of adhesions. When there is no manipulation inside abdomen, I remember, so at that time when we in open era, so then we see, so this is the powder and latex and something like this, gloves and adhesions, post-op adhesions. No issue. Just with tiny holes, we do this surgery, very less chance of adhesions. Many times when I do laparoscopy due to any other reason, there is nothing inside. So this is the beauty of this. Early return to work, less pain post-operatively, and also less surgery associated complication. When there is no laparotomy, definite, then there will be less chance of such pneumonia and also atelectasis and also thromboembolism. So this decrease and also early mobilization, that is the most important, as well as cosmetic. Yes, I highlighted here. Why I highlighted? Because my viewers are also Pakistani, and I know there are some issues, so little expensive. So it depends on you, depends on your setup. If you are already used to, then there will be no more operative time. But yes, this is also a factor, because we have lot of cases in Pakistan in a hospital. Maybe it will take more time as compared to open, but potential for, if surgeon is inexperienced, so definite there is more chance of complication. So due to this, learning curve is more important. Who is doing this surgery? Because in experienced hands, yes, then we can go ahead. But if someone whose learning curve has not completed, so then definitely there is more chance of complication and less tactile. So it depends on the expertise, and maybe so difficult in complicated cases. It depends on the expertise of the surgeon. So contraindication, as we have also in open, but here in laparoscopy, because we do pneumoperitoneum, so severe COPD, cardiac disease, grade 2 or 3 shock. Generalized peritonitis, again, it depends on the surgeon expertise. Previous extensive abdominal surgery, if there are some laparotomy, again, it depends on surgeon experience. Previous generalized inflamed disease or radiation. and hyper or hypocoagulable states, advanced stage of pregnancy, and suspected carcinoma. Again, suspected carcinoma, again, I am asking this depends on surgeon experience. So carcinoma, when we highlight, this means gallbladder. If you are doing lap chole and there is suspected carcinoma, gallbladder carcinoma, but overall malignancies like gastric malignancies, colon, we are routinely doing laparoscopic and robotic. Yes, there are specific, if patient is cirrhotic, sickle cell disease, AIDS, or ectodermal dysplasia, then be careful. And so when you are doing this. So diagnostic, so you can see Kelling in 1901. So he started, and this was electronic eye inside abdomen. And now we are sitting in 2023. So more than one century. So surgeons are doing something in the benefit of humanity. And now we are sitting in this era, we're talking about artificial intelligence. So we must acknowledge these guys who started this. And now we are at this stage. So when laparoscopic cholecystectomy, no doubt this is a gold standard at the globe. And now most commonly perform minimal access surgery. And now 97, I can ask so about 100% lab colis are doing with the lab colis are doing. So this is not now open surgery till difficult cases. You can do, again, it depends on your expertise. That is the most important. So just I highlighted someone for our youngsters, especially because maybe they will also watch this video. So we can do all of these surgeries and you can see the results. Then laparoscopic splenectomy, there is no scar. But this young girl, so you can see incision if you will do open. So this is the beauty of this surgery. So you can use in different like ambiguous genitalia and also colon and Hirschsprung disease, pull through. So this is just some pics of some surgeries and this fundoplication. Also now we are so much easily doing this, and especially the patient with the G reflux, if our hiatal hernia, if need, and many things, indication, there are many indications. Then you can go for fundoplication. So also again, these are the laparoscopic bariatric surgery. Nowadays, this is the, so because my main practice is also bariatric surgery and weight loss surgery. And also I am practicing or doing surgery for type 2 diabetes. Patients with suffering with type 2 diabetes and BMI 30 plus. We are also doing some types of surgeries in these patients and amazing results. So you can see, so from we started, if remember, gastric band, and nowadays I can so ask for more than 10 types and more than 20 types surgeries. We're doing Roux-en-Y gastric bypass, mini gastric bypass. We are doing sleeve gastrectomy. We are doing SASI, SADI, SAJ, gastric plication with ileal bypass, BPD, duodenal switch, many things I can count, and also now endoscopic surgery as well. So thoracoscopy, so also this is the beneficiary. So there is no rib resection, no sternotomy, minimal morbidity. So these are the advantages. So definite, so you can do this surgery much easier and better. So if our surgeon knows, so they definite are doing esophageal atresia and open, no need, just you can do with 3 trocars and easily you can perform such a surgery. Nephrectomy, till you can remove your kidney with the laparoscope, especially for as a donor also you can do, and just with the incision in that kidney areas and you can remove your kidney. Or yes, hand assisted laparoscopy also is helpful. Now we are talking about mini and micro laparoscopy. The size of this thinner as compared to previous. and also many others surgeries we can do. What is the future of laparoscopy? Now, surgeons are operating exclusively via computer interface, controlling a master slave manipulator mouse, that is a robot. And also, we know different names in the market, and this is the globalization of surgery and master slave manipulator. That is amazing, really. And if you see, so what is the role of robot? Definite till this time need surgeon is there sitting there, guide the robot, because robot is now as an instrument. But we will touch about artificial intelligence of robot. In future maybe more intelligent, but also now till now we are using as a instrument, and amazing result, different names now in market, and also just in Arab Health this year in Dubai. So Medtronic also, again last year also they present this, they are about, we have CMR, many names now in the market, and it is for humanity, for the better results. So if you see artificial intelligence in robotic surgery, there are some benefits of robot: greater range of motion and highly magnified, high resolution, better access to the area like pelvic areas, and shorter hospital stay, less risk of infection like laparoscope, less blood loss, less pain, faster recovery, a quicker return to the daily routine. But again, it need expertise. So how about, so this is a with tiny incision, like and also you can, because your instrument is smaller and mine size is smaller, and also surgeon manipulate instrument to perform operation till this time. So minimal invasive motion, scaling, and thermal filtration, because in hand maybe, but when robot wrist is more angulation, and also enhanced accuracy, more comfortable, low risk of infection, faster recovery, enables remote surgical procedures. We believe that all types of surgery are moving toward using this technology. And robotic surgery of future, the robot arm will automatically scan tissue and present the results to the surgeon in a 3D display. The system will help the surgeon plan to the best path to remove the lesion. The robot's interface will enable the surgeon to easily perform the surgery. Artificial intelligence is gradually changing the practice of surgery with advanced technological development of imaging, navigation, and robotic intervention. Recent successful and influential applications of artificial intelligence in surgery are reviewed, from preoperative planning and intraoperative guidance to the integration of surgical robots. With the development of artificial intelligence techniques, surgical robots can achieve superhuman performance during minimal invasive surgery. The objective of artificial intelligence is to boost the capability of surgical robotic systems in perceiving the complex in vivo environment, conducting decision making, and performing the desired task with increased precision, safety, and efficiency. So if we can summarize this one, so this is perception, localization and mapping, system modeling and control, human robot interaction, as overlap exist between intraoperative guidance and robot localization and mapping. This section mainly covers the methods for increasing the level of autonomy in surgical robots. So if you see here in the slides, so we need definite the cooperation and control of surgical robotic system. This is a touchless manipulation, interaction mediums between surgeons and intelligent robots. Just a minute. And also, these robots usually throw surgeons gaze. Now we are working on this. So there is no need manipulation with hands, just with gaze, just with head movement, speech, voice, hand gesture. So robot will follow. And this is the artificial intelligence. And 2D, 3D eye gaze point of surgeons tracked via head. Nowadays, we have a console, we sit inside and just we manipulate. But now we are doing and this. So then there will be no need till hand manipulation. And also in this, I will highlight here, you can see this is when we ask, so artificial intelligence, we can see here we have some preoperative. This is the technology and what is our target. When we see, when we have such a situation, then we can achieve better results. So then you will see, so this is a visual odometry, structural mapping, feature tracking, image registration, and then your results will be much better. So we are going to achieve such a target. So nowadays, when we do traditional laparoscopy, there is a surgeon and verbal comment to surgical assistant. I will ask, so do this, like this, do like this. Then surgical assistant will help you. Then you can do surgery and he will do or she will do camera movements. I want to see this area. I want to see this area. But laparoscope, by robotic, so surgeon is sitting in the console. There is no assistant and surgeon will control the camera movement. Will control, must control, then we can do. But what is the future? So there is autonomous camera controller. Till no need to do surgeon with console. So this will be artificial intelligence and we are going to this era. If you see here, definite, so we need some cooperation as well. For training purposes, we must train our team, our surgeons, then we can go ahead. It is easy to go to achieve this target. So if we see here in this slide, so this is, we can see there are many meta learning and explainable artificial intelligence, early detection and diagnosis based on multimodal information. So surgical robotic, more versatile, lighter and cheaper. Increased level of robotic autonomy and also nano robot. And again, if we see the guidance shift from this static image to display dynamic, advanced AR and VR technologies, remote surgical cooperation between multidisciplinary teams. And also we must follow these ethical and legal issues. So if you see the robot, here is robot, okay? We have nanorobot, surgical instruments, and Da Vinci that is still leading at the globe. And yes, maybe there are some monopoly and so these are some confidential things. So if we see this, what is our target? So this is system modeling and control. So this is if you see kinematics and dynamics modeling, learning from demonstration, reinforcement learning. And if we see human robot interactions, then cooperative control, touchless manipulation, intention understanding, and prediction. And again, if you see this perception, so there is instrument tracking and segmentation, 3D tissue tracking and reconstruction, surgical tools and environment interaction. And if we see here localization and mapping, augmented reality, visual odometry, and camera. Because in laparoscopy, in robotic surgery, our leader is our camera. So we follow that one. And if you have camera localization is perfect, then you will do the best. This is the base of our surgery. And then simultaneous localization and mapping. So this is the robot, and I was in Centennial, Texas, because I am fellow of ASMBS, and because yearly we have a meeting, and this year we were in Centennial.
So you can see here
I will
how
highlight.
it is working. It's amazing. See how patient is very helpful.
This was an exhibition, and I just highlight there was lot of technologies, and now you can't believe this was why I show this one. In that conference, 100% presentation was robotic surgery, and there is no laparoscopic surgery. Just still we are sitting in open surgery in Pakistan, because on monthly basis I am there and I know everything about. And you can't believe, still in Pakistan there is no training center. There is no one training center of laparoscopy, not robot, laparoscopy. Till we are doing lap chole and someone lap hernia and only this. So now we must do something for our nation. This is the right of our Pakistani people to entertain such a facilities. So this also I highlight this here for our youngsters, simulation for hand-eye coordination. This is artificial intelligence. And with this instrument, you can improve your hand-on surgery with simulation. When I was watching inside like this, so these are so for stitching, tissue grasping, this is artificial intelligence. We have now grasper, that is also intelligent grasper. When you grasp the tissue, so there will be some signals. So this is amazing. So because previously, now we have just grasper like single action, double action, different fenestrated, automatic. We have tactile with laparoscope, but that are not, that routinely we use, that are not intelligent. But now we have intelligent grasper. We can see this, how much this thickness of tissue, because when we use stapler, when we use, so we must know about the thickness, because if we use some that stapler that is not perfect for that tissue, then there will be chance of leak, there will be chance of bleeding. So this is artificial intelligence, how we are going ahead. So one of the example of this is intelligent grasper. You can see, and this is working on, this is a grasper, but working like a robot. So, and also this is intelligent and three-dimensional grasper. And now we are in this era. We have three-dimensional intelligent grasper. Then it is much easier for us to detect the tissue and also to work with such a instrument. Then there will be less chance of complication. Just now you can see this is 3D. So this is 3D and also intelligent grasper. So we have energy sources in laparoscopy and robotic surgery, because without this energy source, we cannot do surgeries. Like we have bipolar ligature, that is also this artificial intelligence. And now we have, so we can detect the tissue, for which tissue we can use, which size of this vessel we can seal up. So this all is artificial intelligence. We have Enseal, we have Sonocision, we have Thunderbeat, and also this I am using now ligature here during surgery, because when you use this one, yes, at this time I was doing bariatric surgery, and also you detect the tissue, you hold the tissue, you seal the tissue. So how much our surgery faster now as compared to previous? We have such a technology. We have now this powered staplers. So previously also we have simple one, but at that time we cannot detect the tissue. So if I am doing a sleeve gastrectomy, antrum of stomach is thicker than fundus. So we cannot use same stapler for antrum, same stapler for body, same stapler for this fundus. Same in male patient, female patient, young patient, thickness of stomach is different. So if I will use thinner for thick size, thick part of stomach, there is more chance of leakage. And if I use the more height of stapler for thinner part of stomach, there is chance of bleeding. So how I detect? So now, yes, I can detect. This is thanks for artificial intelligence. Now I have powered stapler, and I can check when I can see the light. If there is green, go ahead. If there is red, no, 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 this is not good for this tissue. If there is yellow, then I can select. So this is amazing. Now my job is much easier due to this. Now you can see less bleeding and less leakage. So if I remember in just 15 years ago, lot of leakage, many complication, because why? If we compare this technology till stapler, much better than 1 decade before, and maybe in future we will see much better. Also, you can see here I'm using that forward stapler. So in sleeve gastrectomy, I am using here. I can detect. So this gun and also the stapler. So inform me which stapler I must use for this tissue. Which one is better for the tissue? This is artificial intelligence. So again, I was in San Antonio, in Texas, and I can show you this one. This is now we are starting. So again, this is artificial intelligence. And also we can detect the tissue, we can choose the tissue, we can choose which stapler is better for our surgery. So again, one thing that is also very interesting, role of ICG. The main issue of our surgeries, we cannot, before this, we could not detect ischemic area. When we are doing surgery, maybe there is some ischemia, and then in future, maybe patient will face leakage, patient will face marginal ulcers and other complications. And as well as if we go for lab chole, sometime there is difficult to make that critical view, and there is chance of injury to CBD, but now less chance. This is again, we can ask, so artificial intelligence. So you can see how we do this ICG, just we inject, and you can see this fluorescence guided surgery. Amazing. And you can see anatomy. It is easy for us. This reduce complication, better surgical outcomes. So when we use ICG and we inject intravessel, then intravenous especially, and you can, if you are doing this colon surgery and you want to see how much there is any ischemia, always we think about this. If there will be ischemia at this part and we will do anastomosis, so then maybe there will be some issue when we inject ICG, indocyanine. And then you can see though inside your blood, and so this ICG will be there in the body. And if you're doing lap chole, if you're doing colon surgery, anywhere, so it will show. So when this is the white light, because now we have different types of laparoscope. When you will be near infrared light, you will see like this anatomy. So, and also then clear visualization of anatomy. Our different, like I don't take now like Olympus, like Striker, many laparoscope, we have such a facility in these systems, and it is much easier for a surgeon to detect the tissue, and then you can go ahead. So also now the role of endoscopic suturing and overstitch. So this is also one of the part of artificial intelligence, and we take the help. And I will show this for our youngsters especially. They must go ahead.
This was hands-on. I will show you some mechanisms we have. Special station. See the stomach.
So again, a minimal invasive surgery, be committed to provide our community this surgical procedure of new millennium. So just I am interested to show you this short video of 1-2 minutes. I think it is maybe not working. If it was working, it was amazing. I will try to show you this one, and maybe it is not working. I will stop this and I will go to here and I try to show you if I can. And maybe here I can see this video. That was interesting, and I don't know where this is. Maybe I show you this if I can, then it will be. Sir, can you see this one or no? Not yet. I think
No.
video is not clear. This, yeah. Okay, sir. Overall, this was maybe I was interested to show you that video. That was very interesting video. If I have time, I can show you. Just I will go here. I will go here, and I will try to show
You can change the share.
Yeah, sir. I will play the share. Absolutely agree with you, but here I can show you this video. I think this is a little find that video. Okay, sir, this was maybe that is not working now, but overall that was also a message for artificial intelligence, how we can do, and we can this artificial intelligence can play a role, especially in robotic surgery. So much thanks, sir. Any question?
Thank you so much. Before starting the question and answer, I will ask Dr. Gohar, are you there? Dr. Gohar?
Yes, sir. I'm here.
Dr. Gohar?
Yes, I can hear. Yes, I'm here.
Yes, Dr. Gohar, yes, you can give your comments, Dr. Gohar, and then I will ask Professor Luqman. Dr. Gohar?
Thank you very much, sir. I pay my gratitude to respected Professor Dr. Mulazam and Professor Dr. Imran for depicting such a great academic presentation for all of us and giving us this opportunity. Sir Imran, I'm
Yes, sir,
really
please.
so proud of following you on social media that you are going worldwide and presenting Pakistan and your great work. And I will take the opportunity to sending my thanks to you that recently you have appreciated my case of Moynihan thumb, and that was on the global laparoscopy social media portal. Thank you very much, sir. Sir, one thing I would like to say that the laparoscopy or minimal access surgery is not the luxury, but is the necessity of the millennium. So we will have to proceed, go forward with this concept of excellence. Only that way we can improve and incorporate this new skill in our surgical practice. And recently I have attended my fellowship in minimal access surgery from World Laparoscopy Institute at UAE by Professor Dr. R.K. Misra. And I totally agree with you that in Pakistan we lag behind because we don't have dedicated centers for minimal access surgery. And only such kind of webinars and seminars and sessions, they can generate the interest of our young surgeons, and they can be a part of encouragement. Thank you very much, sir. Thank you for your
It's
time.
great honor.
Professor
Great honor
Lukman?
for me. Great honor.
Yeah, I think it was a great opportunity to hear Dr. Imran Abbas talk about artificial intelligence and surgery, and give us a very nice overview on the subject of minimal access surgery, the entire gamut of procedures which can be done with a minimal access, whether they are laparoscopic, robotic. It was a great opportunity, and I think I'm very, very thankful to Professor Mulazim Hussain Bukhari for inviting me to be a part of this forum. And I am being introduced for the first time, and it's a great opportunity to be here. And the only thing that I feel on the subject of artificial intelligence is that that it is now a necessity, not only from the perspective of from Pakistan, but it's a global one right now. And second thing, that Pakistanis should make more effort to be innovative, or to move towards such centers where such innovation is a routine, so they can improve their skills and they can open new opportunities for themselves. So I think that's a wonderful way of starting, and I think Dr. Imran Abbas did an amazingly good job of giving us an overview of the subject of artificial intelligence and robotics. Thank you.
Looking forward, Dr. Imran Lukman, next topic
Yes.
on it. Dr. Imranuddin, Dr. Imranuddin, you can ask the question you have raised. Dr. Imranuddin, there is one question from the Dr. Imranuddin to the Dr. Imran Abbas and Dr. Lukman. Is there any training slots available in your institute for this surgery?
Sir,
I think, yeah, please go ahead, please. First, go ahead.
in Dubai, so it is little difficult. But again, we have started our academic activities here as well, because Dubai Health Authority has lot of restriction, because we can do but only on simulators and wet lab. We have in Sharjah wet lab, and we routinely use that. But as a hands-on surgery on human being in operation theater, little difficult in Dubai, because their rules are restriction so much. But yes, we can do. We have a lot of master classes here, and also you can participate. We do live surgeries, but you cannot come inside the operation room. As an observer, you can. But again, in Pakistan, yes, routinely I am doing there, and just now this March I will be in Islamabad, 15, 16,
And
17.
also in Kashmir.
Inshallah, in Kashmir as well. And so hands-on surgery routinely I am doing in Pakistan, I am doing in Uzbekistan, in Iraq, in Nairobi, in Tanzania, in many countries. But in those countries, it's much easier to do as compared to UAE.
Thank you. Dr. Imran, can you ask another question, Dr. Imranuddin Khan? Because there are so many questions. Dr. Imranuddin, you can unmute and ask the question. Dr. Imranuddin. Okay, Dr. Gul, Dr. Dayali Gul.
Ji, Assalamualaikum. I am very thankful to you that you have given opportunity to listen here. Very good lecture, very informative. I
Thank
have one question. As a patient came with multiple surgeries previously, just like cesarean section or any other, and she came for now hysterectomy. Either I am asking it is beneficial for the open surgery or the laparoscopic surgery for hysterectomy.
Doctor, it's a good question. It depends on, again, your expertise, because patient has previous cesarean, and definite that area is already manipulated, and there will be lot of adhesions. So
Possibility.
possibility of lot of adhesions. Again, it depends on your expertise. So if you can go for laparoscopy and you have excellent experience, as well as energy source, that is also important, then go for minimal invasive surgery. You can go. There is no restriction. Okay. There is no compulsory to go for again laparotomy or that area incision, open the incision. So we prefer MIS. Personally, I will prefer laparoscopic hysterectomy.
Okay, thank you so much. So kind of you.
Dr. Kaisar Sajjad. Dr. Kaisar Sajjad.
Yes, thank you very much, Dr. Mulazim, for giving me this opportunity. I definitely again congratulate and thank you for to Dr. Imran Abbas for presenting a fantastic presentation and providing the information regarding the topic, laparoscopic and the robotic intelligence. My question is, do you have...
I cannot hear, sir.
Hello?
Sir.
Somebody has
Unmute.
unmute. Now, can you hear me?
Yeah, yeah.
Yes, sir.
Okay. So, Dr. Amir, do you have any experience? Because I am an ENT surgeon, I would like to ask about my field. Do you have any experience regarding any ENT surgery through robotic? I mean, laparoscopic surgery through robotic. Do you have any experience? Number one. Number two, that most that the larynx is the more suitable area for benefiting the people through this procedure.
Dr. Imran Abbas.
Yeah, sir, regarding, so because Dr. Kaisar is ENT specialist, so personally, so I have some experience of thyroidectomy, parathyroidectomy, transaxial, that we are,
okay, yes.
I am doing routinely transaxial thyroidectomy, transaxial parathyroidectomy. But some of our colleagues, they are also doing transoral, but I am doing transaxial. Regarding your typical ENT, yes, my colleagues, I can see in my operation theater, endoscopic surgery, they are doing, and also because this is not my field, so maybe I cannot explain more about typical ENT, but yes, regarding thyroid, because thyroid will overlap each other, ENT and also general surgery, yes, I am doing routinely transaxial thyroidectomy.
Okay. If you have, maybe Dr. Mulazim have your contact number. If you like, if we invite you in Karachi just for presenting the axial approach of this endoscopic thyroid surgery, so I hope that you will visit in Karachi for any your presentation.
It will be honor, and also Professor Mumtaz Meher invited me, and I was there in South City Hospital, Clifton.
Yes.
And this was my first time in Karachi, and also hopefully this will be not last time. And I did there a live surgery masterclass, one anastomosis, gastric bypass, and more than 100 surgeons were there. And it was great experience for me. And we have also, I must highlight, we have also GLR, Global Laparoscopy Robotics, Karachi chapter, and Professor Rahman from Aga Khan Medical College and Hospital, Rahman Alvi. Maybe you know his name. He is our chapter president and director in Karachi. And definitely
Yes.
Okay.
Yes, I'm working, Imran, I'm working at South City Hospital. Maybe I miss your lecture at that time. So next time I will request Mumtaz Meher Saab to invite you.
Definitely.
I will be there. Inshallah.
Thank you very much.
Okay, Professor Rafiq Khanani, teachers of the teachers, very senior teachers. Sir, you have raised the hand, sir. Professor Rafiq Khanani.
Yes, thank you, Mulazim. Being a microbiologist, I will just make a couple of comments that surgeries, we are seeing less and less wound infections. And that's a great blessing because antimicrobial resistance, particularly in certain hospitals of Pakistan,
meeting you. Just give me 5 minutes. I'll get back to you.
So I think that we definitely need more and more endoscopic and laparoscopic surgeries to prevent spread of antimicrobial resistance, and of course the hernia and so many other complications. So that's a great initiative, and I think that all the healthcare professionals will support it. Thank you.
Oh, thank you, sir. Dr. Gohar, you want to ask the question, Dr. Gohar? Dr. Gohar?
Gohar, unmute.
आवाज नहीं आ रही.
Unmute, yes.
Sir, can you hear me, sir?
Yes.
Sir, I have a question to Varsi Professor Imran. Sir, regarding sleeve gastrectomy, as you know that traditionally we use this endostapler and they are not that cost effective. I have seen certain videos by Iranian surgeons. They are doing this fundoplication of sleeve gastrectomy. So I would like to ask what is your opinion and experience regarding this procedure? I found that very convenient, especially for the regions here where we have lack of sources, lack of finances and all these gadgets.
Yeah, thank you, Dr. Gohar, for this question. I remember in 2000, when due to sanctions, so this stapler was not easy to take by Iranian surgeons from US. At that time, Professor Talebpour, he invented, so because he asked, so I must do something new. If there is sanction, we don't have stapler, so we must not stop. And also this is a great, in my opinion, inspiration for our nation. He started gastric plication. And personally, I did hundreds of cases, gastric plication. And also in 2016, I added a loop to this gastric plication. Now what I am doing for diabetic patients in low BMI, so I am doing gastric plication, that is not very tight plication, and then I add jejunum to antrum, enterojejunostomy. It depends on the BMI of patient, comorbidities, age, and gender. So then we select that. Amazing result. And now routinely I am doing for, and this is really cost effective, I present this presentation in Oxford University, in Germany, in Spain, in many our IFSO meetings, in London, till I present my cases, my data, as well as my technique. So how I am doing, and definitely when if we can arrange such a masterclass in Kashmir, and I will show you how I am doing this. And this is really just you use 2 or 3 proline, nothing, cost effective, and it is very beneficiary for our region and our patients.
Thank you so much, Dr. Imran Abbas. एक Malaysia से सवाल आ रहा है. Dr. Mubashir is the king of IT, and Dr. Mubashir, you can ask the question, Dr. Mubashir.
Thank you, sir. Wonderful presentation, Imran Bhai. Excellent work. Always hats off to you for your wonderful insight into the robotics and surgery and AI. So I just wanted to share an anecdote that when autonomous cars started in early this century, so there were every 300,000 frames, there was a mistake, an error. Means every 300,000 frames, the cars will not understand what is the image in front of them. Now, if we think this in robotics and AI surgery, you will be amazed that in AI-based surgeries, like all of the body, whole of the body can go through a surgical procedure in future. And that future is actually already there, that in retinal surgeries, the UK-based surgical procedures were done about 4 years ago, and they all use that AI-based approach of visualization. So AI was deciding whether to take an initiative of like ligation, doing some closure of that dissection, closure, all those, but just on the vision of robotic vision, not human vision. Doctors cannot even think, or their eyes cannot see that, or they cannot understand the complication at that level. So thinking, anecdotally thinking, or maybe even it is a reality now, that in the future, these surgeries will be more of robotic surgery than human-based surgery. Humans will be just maybe entering some scope or something. Thank you, sir.
Dr. Mubashir, this is a great comment, but again, because we learn from our mistakes and this is the human being, Due to this, we are little slow to depend on robot. If you see in robotic surgery, so we are little slow, no need to speedy to go, because we must so minimize this chance of any mistake, because we are with a human being. And again, if I must highlight, if you see robot, there is no tactile. In laparoscope, we have some tactile. But again, now we are doing our best. If you see the history of robotic surgery, initially there were a lot of complication due to no tactile. There is no tactile, nothing. But again, it depends on your experience. Definite, when we will start and we will depend on robot as an artificial intelligence, so then there will be less chance of complication.
May I say something here? May I say something here? I think the artificial intelligence, the way it has moved now, and I have been a part of a team, surgical team, which has done a lot of work on artificial intelligence. You know, I will really appreciate the comment of Dr. Mubashir, because Dr. Mubashir has raised a very pertinent point of pattern recognition. Because the pattern recognition is how the data has improved our understanding that the risk of a complication becomes less if we can predict the prediction of a step, that we predict what will happen if we touch an object, a structure in the body, and we can predict that what is the level of the depth, what is the variation of anatomy. All of these things can now be sorted out by the help of artificial intelligence and machine learning, because now we have the ability to collect all the data, collate it, and to make a kind of a pattern recognition. And that's how it has improved our understanding of, of anatomy, of the variations of anatomy. Because I see in my practice where I work that, when we incorporate the images, we have a system here where I work that we can, on the same screen, we can see the image that we are operating on, as well as the variation of anatomy. So we collect those two things together, and we can predict that this arterial variation or this nodal station variation, how would it be, and how we can access it. Along with that, obviously, the ICG, as Dr. Imran Abbas has said. So I think the subject of artificial intelligence has many layers, but it all has ended up, as Dr. Mubashir said, on better prediction and of ease of surgery. It eases the burden on the surgeon as well, because the surgeon it improves, his performance certainly improves with these aids.
Sure. And then
not only,
that 300.
Not only, Dr. Mubashir, it is not only reducing the burden of the surgery, it is also reducing the burden of diagnosis.
Absolutely.
And also reducing the burden of surgery. Dr. Mubashir, we conducted the research with you, and there are so many devices according to the artificial intelligence. How can we write a proper paper? How can we correct a proper
paper? From this particular presentation, sir, if we can ask our Salport guys to start producing equipments based on AI based and robotics and laparoscopic surgery, we can do wonders. Pakistan is amazing country for all these.
Thank you so much for this one.
Right.
And now, because time is over, I will request Professor Salma Kundi, if Professor Qazi is there, Dr. Qazi is the president of SMAO. If Professor Qazi and Dr. Iqbal Dogar is also there, principal of Gujranwala. Can you ask something? Dr. Iqbal Dogar? Dr. Iqbal Dogar? Okay. It is over to you, Professor Salman Kundi, madam.
Thank you so much, Mulazim sir.
Professor Dogar sahab wanted to ask something. Professor Dogar is
thank you very much, Professor Mulazim Bukhari, for a nice presentation from dear respected Imran Abbas. I think AI has very extensive role in diagnostic as well as in therapeutic radiology. And definitely in Gujranwala Medical College, we will like to have
पिछले दिनों हमने किया था ना रेडियोलॉजी के ऊपर आर्टिफिशियल इंटेलिजेंस डीप लर्निंग मशीन लर्निंग के ऊपर
जी so we would like to have these type of activities in Gujranwala Medical College for our undergraduates and postgraduate students as well.
Inshallah, sir. Inshallah. Over to you, Professor Salma Kundi, to conclude today's session.
Thank you, Professor Mulazim Saab. Thank you so much, Dr. Imran Abbas. It was a pleasure listening to you. And I hope one day in Pakistan, we get all these facilities. Even in a small place like Ahmedabad, we are doing laparoscopic surgeries, but the robotics so far have not been introduced, in which it is always surgeon-free and the machines operate on that person. But it is so good to know you are excelling in that, and you are most welcome whenever you have the time. While going to Muzaffarabad, please do come to Ahmedabad. We can arrange some seminars for you. There are 4 medical colleges over here, and we can all, you know.
We will also invite Dr. Luqman, madam.
Okay, sure. That would be great. And recently, my mother was operated. She had a laparoscopic surgery. She had adenocarcinoma of the stomach, and a very good job was done by Shifa International, Dr. Ghulam Siddiq. I'm really happy with the laparoscopic surgery. तो अल्लाह आप सबके हाथ में शिफा दे जी, और अल्लाह पाक ह्यूमैनिटी के लिए इसके बहुत फायदे दे. When we were students जी, जितने लंबे incisions होते थे और गंदे stitches होते थे, और वो patient बेचारा सारी उम्र के लिए scarred होता था, especially the ladies. Thanks God we are over that phase, and one day everything would be plastic and there would be no scar visible. And hope everybody, Allah endows everybody with good health. Thank you again, Dr. Imran Abbas, and thank you to all the participants. Thank you, Kaisar Sajjad Saab, because we from the PMA Forum thank all of you, and special thanks to my dear brother Mulazim Saab.
Thank you,
Have
madam.
a nice weekend. Take
Thank
care.
you, madam. Allah Hafiz. Allah Hafiz.
Allah
Professor
Hafiz,
Imran,
Sheikh.
Dr. Imran, Professor Luqman, thank you
Great
so
honor.
much. Thank
Great
you so
honor.
much for this honor.
Thank you.
Looking
Okay, ji,
forward.
thank you very much. Khuda Hafiz.
Khuda Hafiz.
Allah Hafiz, Sheikh Kaisar bhai.
Allah Hafiz.
Khuda Hafiz. Thank you.